Okay, I think we should start. There are still people trying to get in, so hopefully they will be in before the actual presentations start. Welcome everybody. My name is Peter van Ooijen. I'm working at the Data Science Center in Health of the UMCG. Today we have our next DASH webinar, the first one after the summer holidays, on value-based healthcare, the power of data and collaboration. But before we start, I first want to do a little introduction on what DASH is about and give you some background on that. DASH is a UMCG-wide group of people that is working on increasing the use of data science in health in the UMCG by doing different things, and you see that here in our overview. We run projects and we support projects of other people. We work on collaborations with industry and also with other hospitals, and the session of today is an example of that. We work on community building, trying to get people together to do something in data science, to share knowledge and to increase the use of data science and also the quality of the data science that we use within the UMCG. We look at funding opportunities in this field. I'm running the machine learning lab where we actually perform the data science. We do the deep learning and the machine learning on medical data. We look at the needs assessment, so these sessions like this are also for that, to hear from you what you would like to learn and what you would like to know. Education, well, we have the webinars, we have our mini courses that are also online. So if you want to know more, go to our webpage and sign up for our newsletter, and you will be informed about all the things that we do. And also communication within the UMCG, but also outside on different things that are going on in data science within the UMCG. So for today, I would like you all to put your microphone on mute. I think everybody already did that. If you want to ask a question, you can do two things. One thing is to go to the chat. If you go to the right of the screen, you have that purple button. If you click on that, then it will give you a menu where you can join in the chat and type your questions there. Another thing you can do is raise your hand. There's a button in the bottom of the screen. If you press that, like I did now, then I raise my hand, and we can see that on the screen, so we know that you raise your hands, and we can give you the microphone, and then you can open your mic and ask your question or make your comment or remark. Please, after you did that, put down your hand again, so we don't get too many people with their hands up. When you type something into the chat, it might be that the presenter will pick it up right away. It might also be that we wait until the end of the presentation, and then we will handle all the questions in one question round. So that's for the practical stuff, and then now for the introduction of the two people that we have today to present at this webinar. For today's webinar on value-based healthcare, the power of collaboration, we have two speakers. First, Heleen Hoogeveen, senior data analyst at Martini Hospital in Groningen. She will share future perspectives regarding data as an asset in value-based healthcare. And then next is Joris van Dijk. He is a researcher, innovator and manager at the Isala Hospital in Zwolle. And he will talk about the growing demand for medical information and how to provide insights into this information to healthcare professionals through self-service dashboards. So I think these are two very interesting topics, very interesting presentations. So without further ado, I would like to give the floor to Heleen Hoogeveen to give her presentation.
Yes, thank you, Peter. Thank you for your introduction. Also, thank you for the invitation to share our experience on value-based healthcare. I'll share my screen with you. Okay. Can everybody see it now properly? Or anybody who doesn't?
Yeah, I see it.
Okay. Okay. So good morning, everyone. So I will present our experiences that we have in the last 4 years on value-based healthcare with you. And indeed, as Peter mentioned, if you have some questions, please raise your hand in between. I'll try to answer them during the talk or otherwise afterwards. But first, to start off with, I would like to to have a bit of an idea who's on the other side of the screen, and also what you think is the biggest challenge of data-driven healthcare improvement. And Linda will start a poll with these 5 options, and I would like to ask you to give an idea of what you think the biggest challenge. Maybe I should stop screen sharing. No?
Poll is still running, Heleen.
Yeah, but okay.
So I think we can.
I don't see the poll anymore.
Oh, there is a button in the at the bottom of your screen with the colored bars. If you click on that, then it will pop up.
Oh yeah, I'm sorry.
And then
yeah.
you can put on the responses, and then you can see the bars with the things that people responded. So we see that 12 people did not give a response. 20 people say data quality is the most important thing. Then the next one is 8 people that say multidisciplinary collaboration. Data literacy and qualified data scientists is both 3 people, and only 1 person said IT expenses.
Yeah, well, thank you all for your reply. And well, on the one hand, it surprises me that most responses are to data quality and multidisciplinary collaboration. And well, I will elaborate more on that, and let's see if that's in the end the case as well. So to go back to the presentation, I think I should then. Okay. So also a short introduction of who's in front of you. My name is Heleen Hoogeveen, and as Peter told you, I have a background in neuropsychology at the University of Groningen, and together with that I also have been a teacher in statistics, because I'd like to puzzle around with these numbers and well, extract insights from different sources of data. And after my studies I did a PhD in neuroscience at the Neuroimaging Center of the University Medical Center. And after that I felt that I got the most energy of applying these well, findings to real clinical practice. So that's why I switched to the being a value-based healthcare data analyst at the Martini Hospital. And besides being a data analyst, I also enjoy mountaineering and being outdoors. So well, that's me. Well, some key figures of the Martini Hospital. Martini Hospital is a Dutch subclinical hospital, 1 out of 28 in the Netherlands. And we have approximately 370,000 outpatient visits, 25,000 admissions, 80,000 surgeries, and approximately, it's always difficult to get the exact number, but around 600 hospital beds. We're a top clinical hospital because we have some top specialties. For example, the kidney center, high care neonatology, neurosurgery, and some other specialties. The Martini Hospital is part of a collaboration of 7 Dutch hospitals, of which also the Maas of Ziekenhuis in Rotterdam, and also Catharina Antonius and the UMCG Hospital in Amsterdam. And we are, well, the strength of our collaboration is that we are very much distributed across the Netherlands. So therefore, although it sounds a bit weird in patient care, we are not competitive hospitals, and this allows us to, well, kind of neutrally compare data from different patient groups. We have currently running a healthcare improvement cycle for 15 medical conditions, as they are mentioned here. And we started with that's called the Big Four. It's breast cancer, prostate cancer, lung cancer, and colorectal cancer. And gradually we expanded this towards, well, 11 other medical conditions that we are now comparing data of and try to improve healthcare with. Well, to give you an idea of the volume of these hospitals, because the Martini Hospital in itself, it might not be that big, but together with the other 6 hospitals, we have a 30% national volume of all hospital services within the Netherlands. And that also allows us to be, well, comparable with, for example, other big hospitals abroad or other bigger patient groups that we can compare with other institutions. So where does value-based healthcare then come from? Santeon, the hospital consortium, was started in 2007, and this is also the time when Michael Porter, he's a professor from the Harvard Business University, wrote a book on redefining healthcare. And he has a background in business, so it was very much oriented towards the cost crisis in healthcare. So how can we at the same time improve the quality of healthcare, but also either lower or stabilize the costs of healthcare? So as you can see on the right side of this slide, he defines patient value as the division between health outcomes and healthcare costs. And healthcare outcomes, you could think of health status or the process of recovery or sustainability of health. And later in the presentation, I'll give you some examples of that. And with costs, you could think of the number of admission days, diagnostics, medications, and surgeries. So in 2016, it's a while after he wrote this book. His book is quite theoretical. And we collaborated with the Boston Consultancy Group to translate this theory towards a improvement cycle that we could use in practice. And the cycle is a period of 6 months that we have twice a year. And this cycle consists of 3 elements. So in blue, you can see that we collect the data and we search for differences. In purple, we analyze and identify opportunities for improvement, so where differences in data are and what might explain this. And if we have a certain explanation for this, for example, why one hospital has more complications after breast surgery than another hospital has, then we continue into the red phase, which is to implement the improvement. For example, to use different techniques to clean the wound or, well, other clinical actions. And so this is a cycle that we perform for all these 15 medical conditions. And what that requires are 2 elements. First, there's a multidisciplinary team and also a Santeon scorecard. I'll give you an example of that. So the multidisciplinary team consists of people from diverse medical specialties, like a breast surgeon, a pathologist, oncologist, and they are facilitated by a value-based healthcare project leader and a data analyst, like myself. On the other hand, there's a scorecard, and this scorecard is defined in 3 steps. First, we define the patient group, for example, breast cancer patients. Then we define treatment options, whether these patients have chemotherapy, radiotherapy, or other treatments. And then we define, we call them indicators, and they make up together this scorecard. We try to be simple and practical and also align with international standards like they are defined by the International Consortium of Health Outcome Measures, ICHOM. And also we would not like to increase registration burden, so we very much aim to use existing data. So to give you an example of these indicators, so here you again see the balance between outcomes and cost, as Michael Porter defined this as value. And in addition, there are some process indicators in red. So to give an example of outcome indicator, it could be the percentage of participants that has a reoperation due to positive margins. And an example of cost would be, for example, case 6, the use of expensive medications. So this is a set of indicators that every 6 months we gather as data analysts from all systems and compare between these 7 hospitals for these 15 medical conditions. So as you can see, it's quite a big program at the moment. So to dive a bit more into the data, so as an analyst we gather every half year, every 6 months. We combine data from many different sources to compute these indicators. For example, from the hospital system, but also from separate systems like FIFO Health. This is a system from Philips, and we use them to send patients illness-related questionnaires after they, for example, had surgery. There are also some national registries that already gather data from our EMR, like IKNL, which is the cancer registry, and also DICA, which is a registry that that also gathers indicators on these medical conditions. So when we started in 2016, we were very much dependent on these external national registries like IKNL and DICA. But that also makes analyzing data and diving a bit more into detail makes it more complex, because you have to wait for them to get the data, and if something is missing or you would like to have something extra, or you would dive into a bit more detail in your own EMR, you can imagine that it is complex to be dependent on these external sources. Okay. So to have a bit more of an idea of what the data looks like, I here have a bar graph which you see on the y-axis the 7 Santeon hospitals, and on the x-axis you see the percentage of patients, the breast cancer patients, that receive the breast conserving operation in outpatient treatment. And in red it's the first cycle, so the first time we gathered this data, and in black it's the actually the third cycle, because it requires some time to get these improvements going. But what we in the first place saw is that the data gave insight that in some hospitals patients have these operation in 80% of the cases in an outpatient treatment, whereas in other hospitals it was actually 20%. So what we did, or no, well, not what we as analysts did, but there was a discussion ongoing between the different multidisciplinary teams of these Santeon hospitals, but also the surgeons, on how they could increase this percentage. And they came to 3 solutions. One, to have alternative pain relief, so nerve block in combination with some medication, and this resulted in less nausea, and therefore patients could leave the hospital in an earlier phase. Second, we found that there should be more consistent communication on the expectations that patients have when they would leave the hospital again. So the material that was provided when planning the surgery was also adapted to this. And this in the end led to, that the black bars represent a higher percentage of patients in outpatient treatment than the red percentage. So this illustrates how data and the discussion that follows, so these 3 phases of the improvement cycles that I showed you, are in the end reflected in improvements in healthcare. So again, back to how we, as analysts, gather all this data. As I mentioned, in the beginning we were much reliant on these external data sources like IKNL and DICA and also other parties. And we felt that this requires much time, and also it did not allow us enough to dive into more detail when we had certain hypotheses on where variation between indicators would come from. So what we are currently setting up is a way in which we can more easily access this data and also to be more independent from these external sources. So on the left hand you see certain like Higgs and EPIC, which are our EMRs, and also some examples of what type of data you could think of. So it's financial data, it's admission data, pathology data, pharmacology data. What we did is for each type of data we made a format of which data we use quite often. And in that way we could gather this data more easily. And this is called information modeling. So I think much of you or most of you might be familiar with data warehousing. So the data from all these different applications is combined into a data warehouse, in which we also store definitions on, for example, how we calculate length of stay based on admission data, and also this is according to privacy regulations. And one of the projects that we are currently performing is together with NICTIS. This is a national party that helps us define, or that helps us model the information from these different applications according to international standards. I'll not dive into that much detail about this, but what it allows us is that we standardize all these information. So we don't have to talk about the definitions every 6 months, but that the different definitions are more settled. This is a huge job, but we think that it really might benefit us in the future, not only within Santeon, but also to compare, for example, outcomes of breast cancer patients with other hospitals, both nationally and internationally. And then the third element of this slide is that if we extract the data in a more consistent and standardized manner through the data warehouse, then we as analysts can shift our daily work more towards statistical modeling and dashboarding as opposed to getting the data from the application. And in the Martini Hospital, we currently mostly use IBM Cosmos and RStudio Shiny to create these dashboards. Okay. So then I'd like to share with you some key success elements of how we walked along this road. So one of them is that we have a bi-weekly prioritization between data analysts and BI consultants. Because you can imagine that not only from these 15 medical conditions, but also other medical specialties or nurses or managers would like to have insight in some form of data. So this requires prioritization, and we do this through a Scrum method. And the second thing is that, as I said, we standardize these different data formats that we need. But in the beginning, this still required that a BI consultant every week delivered the data to us, which was very time consuming. So what we did in collaboration with our BI department is that we developed a self-service tool for these standard repetitive data acquisition from data warehouse. And this is very useful, as it allows us as analysts to more quickly get extra or new data, and it requires the BI consultants to focus their work on other parts of data extractions or information modeling. And thirdly, we have both within the Martini Hospital, but also at Santeon level, theme-specific working groups, for example, on dashboarding or information modeling. And this is especially useful as the role of a data analyst or data scientist, as you might say, can be quite diverse, and this allows us to, well, on an individual level, decide what you're most interested in, and also what you're most talented in to contribute to. So whereas I might be more interested in information modeling, one of my colleagues is more into dashboarding. So in this way, we divide these specialties as data analysts. And personally, I experienced this as a very nice learning experience or learning platform, as Santeon might be, because we are now currently a group of 25 Santeon data analysts, because every one of the 7 hospitals has these 15 medical conditions, which are, well, facilitated by approximately 3 or 4 data analysts. So therefore, it's also, this creates a nice exchange of expertise. And then especially on our studio, which is the main software tool that we are using. So then to continue, I would like to give you an example of of how we get from these different indicators on a scorecard towards real improvements into the healthcare process, because it is difficult to get qualitative indicators, but the next step that is also quite challenging is to get from an insight towards an improvement. And therefore we developed within Santeon this method, which includes 4 steps and also resembles the scientific method. So if we see some variation in outcome, for example, the number of patients that have surgery, the example that I showed before, then this variation could be due to, well, 4 different elements. It could be the data quality, the way it's registered in the healthcare process. It could also be the patient mix, for example, age or BMI or these kind of characteristics. It could also be that in some hospitals, different decisions to treatment are made than in other hospitals, although there are protocols for this. And as the 4th element, it could also be that the treatment is executed in a different way. So whereas this could be, for example, how they cut with the knife during surgery, for example. So it's very diverse what can explain variation. It's also sometimes quite difficult to really pinpoint what explains the differences between the hospitals, and so what we should improve in practice. But still, to use this 4-step method, we departing from the observation of variation, we first try to define some hypotheses. Then we build a model. It's either a statistical model, but it could also be to compare, for example, treatment protocols. And then we discuss this after 6 months, and in the end, this would then result in really changing something in the healthcare process. For example, like I said in the breast cancer example, to change the information material or to change the way how surgery is performed. And one example of that is to lower the percentage of unpredicted cesarean sections. And we use the logistic regression model with case mix correction across 7 hospitals. So then the outcome would be if there is a section, yes or no. And as we've been collecting this data now for 4 cycles, we assumed that the data quality, this was not the explanation of the variation. So we set apart option 1. And then we build a model including option 2, 3, and 4. So we included age, BMI, length, gestational age, but also whether labor was artificially induced, whether the mother was during transferred from home to Martini Hospital, whether pain relief was given and how this was given, which medications were used, and also whether birth was stimulated or not. So this statistical model led to or guided that each hospital had specific directions for improvement. So for example, for the Martini Hospital, we saw that our opportunities for improvement were mostly into the pain relief and also the medical birth stimulation, whereas for MSD, the hospital in Enschede, their opportunities for improvement in this indicator were more towards artificial labor induction. So this way we are, well, touching a bit upon how to use statistical models to guide practical improvements in the healthcare process. Okay, so to wrap up, as I also see that my time is almost up, I think there are three important lessons that we've learned. First of all, that it's really important to facilitate multidisciplinary teams in an agile and short-time improvement cycle. And by multidisciplinary, I not only mean these meetings with the surgeons, the nurses, the radiologists, the pathologists, but also between the analyst, BI, and IT department. Because that really gets the improvement cycle going. And secondly, it's very important, as you saw, that the first 4 years of our value-based healthcare program, we prioritize data quality and accessibility towards this self-service tool. And this now allows us to get more time to move towards dashboarding and statistical modeling. But if data quality was not, was not proper, we would never do this in a meaningful way. And thirdly, it's very important to start with why and reduce complexity, because in the daily hustle of providing primary care, we often hear that this is interesting and this is interesting, much is interesting. But what we really try to focus on is which elements are interesting, but we also have an idea of how to improve this. And secondly, to reduce complexity. So not to build extremely black box models, but really try to make it as simple as possible. And sometimes this is also a pragmatic way. What we experience is what helps our medical professionals very much is to also not use as few statistical terms as possible and visualize the results on an individual level. Because in the end, our medical colleagues are most into really patient care. So if the results are presented in a way that makes them feel it's really about the patients themselves and not about huge groups of 100,000 of patients, we feel that it triggers them more to get more insight and dive into it. There are also two challenges, which is to learn and improve in the context of primary care processes, because this is always goes first. So sometimes it's really difficult to find time in between the hustle of appointments with patients and acute situations to reflect on data, to learn, to really think about this. That's sometimes really challenging. And also how to deal with small numbers, missing data, and collinearity in statistical models. So that is what I would like to close with. Of course, I was not doing this alone. A big thank you to my colleague data analysts, so my colleague project leads, and the colleagues from BI and IT. So that was it. I think I'll switch to the chat then, if there are some questions.
Yeah, thank you, Heleen. I think there are some questions at the beginning already. Dan put in a remark that he was missing the privacy laws in the poll that you did as one of the factors.
Yeah. I think, yeah, that's of course a good good addition. I think the list could be much longer. I decided to use these five, as I experienced these five to be most prominent. But yeah, privacy is also very important. We have in each hospital a security officer that that is involved in this program of information modeling, and that we can do this in a proper way.
Okay. Two other questions that are in the chat from Koen Peters he asks, are there statistical models used to optimize for the lowest risk? Or how do you deduce which factors to improve for a hospital?
I think what maybe Koen, you could elaborate a bit more on what you mean with a risk, or you mean a high-risk patient groups?
Is Koen still online? I think Koen is trying to make a new connection at this moment.
Okay. Well, maybe the short answer is that we are not using, or I'm not aware of statistical models that are used in daily practice, because our cycle is a 6-month cycle, and we have not yet transferred these data to daily practice.
Okay, then a final question before we move on to the next presentation. Rose put in the question, when you experiment with a new improvement, how do you measure value for the patient itself?
Well, the patient is involved in this improvement cycle as they are a member of the improvement teams. They are a member of the improvement teams, and also when we define these scorecards, we always try to talk with either one or a group or a representation of patients in order to select outcome indicators that are really relevant for patients. So that's in that way we try to include the patient's perspective in it. But yeah, with regards to new improvements, in that phase, the patient is not actively involved. Well, through contact with medical professionals, but not in the data.
Yeah.
I hope that answers the question, Rose.
If not, then maybe the people that want to ask more can put it in or contact you later. For the sake of time, we have to move on. Thank you very much again for the very interesting presentation. Very nice to see that the national collaboration is ongoing in this topic. It's very good that people connect to each other. Now we move to Joris van Dijk. I hope we can get his presentation started. Joris, I give the floor to you.
Thank you very much. I think my presentation is now shared.
Yes, it's on the screen.
I actually want to start off with the Gardner figure. I think most of you are already familiar with this one, and this is actually describing how mature the data infrastructure is in an institution. So you have kind of 4 stages in which the difficulty and the value increases each step. And I actually want to start off with a poll on how data-driven are hospitals currently, and what your opinion is about this. So are they still in a descriptive phase, a diagnostic phase, the predictive phase already, or are they already at the prescriptive phase? Can
you see the responses, yours?
Yeah, I'm getting them.
Okay.
23 people down. Yeah. So most of you say we're already in the diagnostic phase, 16, 7 on the descriptive, and 2 are real positive, and they say we're already in the predictive phase primarily. Well, at the end, I think I have to disappoint you a little bit, because I think we're still in the descriptive phase primarily, although we are urging towards the diagnostic phase. We'll get to that in the end of the presentation. I'll skip this one due to the sake of time. Who's talking? I'm Joris van Dijk. I have a background in technical medicine and health sciences, and I currently work at Isala Hospital in Zwolle as an innovator, as a researcher, but also as a manager. And the innovation is more or less about the data for medical professionals, how to extract those data and present them to the medical profession to improve care. Well, that's our main aim. We are an improved hospital, so kind of like the Santeon group, which Heleen already talked about. We have 6 hospitals, 5 in addition to Zwolle, in which we already also benchmarking. But to switch a little bit the point of view, I don't want to talk too much about the improve situation, but more about the data infrastructure we have and the current demand for data. And I actually want to start off with the moonshot we set to ourselves 4 years ago. That was to support the accessibility of business and medical information for each health professional in Isala, to allow continuous improvement using real-time patient experiences, outcome data, process times, volumes, and cost data. So in the end, what it comes down to is actually for each care pathway, we want to be able to put together the Excel database which describes all your patients with all those indicators. But as physicians do not really like Excel, we actually need to present those in figures, so in a dashboard. And when you have a dashboard like that, you can actually get your improvement cycle started. So that was our main aim 4 years ago. And to go a little bit back in time first, this was still 17 years ago. So the first problem was we couldn't find the file of the patient. And the second one, if you found it, you couldn't read it. So there's a lot of progress made in this period in between. So everything can now be read, and especially the production and finance data is really good structured in all hospitals. However, the medical data, oh, this is going wrong, sorry. And straight away. Crappy dappy. Yeah, that's where. Sorry for that. Yes, but outcome data is often still collected manually. So each surgeon has his own Excel file, and this is insane, but it is true. So ask any surgeon in the Netherlands, and they'll say they have an own Excel file where they put in their own patients to compare their outcomes of themselves and to track those patients. So that's still manually done, while everything is, of course, in a electronic medical record. So it's a large burden. And since 2018, we started off with HICS. That's one of the 2 main suppliers of electronic health records, which is Epic, of course, to the competitor of them. And 30% of all activities in finance are structured like perfectly. You can get them out easily. However, still 70% of all data is in the decursor, so in the free text fields typed in by the physicians. And this is our piggy bank, because it contains valuable information, but of course we have to get it out. And 4 years ago we started with a program called C2Q. It's a commercial software program which we partly developed inside Isala, and it actually works like a Google kind of search engine for within your medical record. So we actually are now able to open the piggy bank and actually access those data as well. And when you look at indicators, what are we talking then about? We can actually now monitor the whole patient trip. So each health activity is registered. And actually when you combine those and put them in order of the timestamp they have, we can actually see the whole patient trip throughout the hospital. We also can, of course, when you look at the times in between those activities, you look at the process indicator, so the times from referral to your first outpatient visit, health outcomes, the need for surgery, second surgery within 30 days, for example. We can look at the DGR, so the DBC in Netherlands, in Dutch, trip, so the facturation. And also we can look at infections, complications, which are written down in the nurse notes or in the physician notes. This is a little bit more burdensome because you have to validate all those, but it is possible if you want to. And actually this allows for a second step which we made recently, and that's to look at the cost of a care pathway, because we have all those activities and we can put a cost price to each of the activities. And what you actually then get is a summation of the total cost for care pathway for each of the patients. And as we have the cost price, we can calculate those. And actually it will result in like graphs like this, like waterfall graphs, which actually, this is like dummy data by the way, but it actually shows where the main costs are given out. So if you want to improve the cycle just purely based on a cost-effective manner, you know where to start off. And you know what to save, of course. Now we have the third one, which was already mentioned also by Heleen in the previous talk, and that's the patient-reported outcome measures. And actually, it has exploded in the last 2 years. We don't use one app like the Veld software, as Heleen described, but we're currently using 10 different software packages to collect those. And of course, this will get you into a little bit of trouble, but I'll talk about the hurdles afterwards. So we actually have all the data we need. Now we have to visualize it. We start off with RStudio Shiny, like Heleen is using, but actually when you want to get a little bit more professional and a little bit more self-service, so people can put their own dashboard together, R is a bit burdensome and technical. And actually we have 3 main commercial software packages available: Tableau, ClickSense, and Power BI, which are real handy and look really good as well. And in the end, we opted for Power BI, so we're currently making our dashboards in Power BI. So actually, all ingredients for value-based healthcare are there. We have the dashboards, we have all the indicators, so we can sum actually the health outcomes, and the costs are there as well. So actually, we are doing value-based healthcare. Well, in theory. When it seems too good to be true, it most often is, and there are quite a few hurdles we still are overcoming and already overcame to get to those dashboards. And the first one is registration, of course. If it's not there, we can't find it. But also a physician don't want to register anything that he doesn't see, and it's purely for the registration. So actually when providing the data in graphs that they don't register well, will increase the registration in a couple of weeks. Secondly, it's like the candy store. We can actually collect all the data they want. So they try a few candies, they always want more. And that's kind of the problem we run into, especially in the beginning. So the first development trajectories were like over 2 years, because each time they wanted a little bit more, and the dashboards became more and more complex. And of course, the work which is put into it became also more complex. So the lesson learned from this stage is actually start simple, make a dashboard, try it, use it, and evaluate it after half a year to improve anything else. And actually, we took those into the value-based healthcare cycles. I won't go into detail about this, but it actually shows that within the multidisciplinary team, which also involves patients, by the way, the indicators which are presented in the first dashboards are selected. So the group of physicians, nurses, but also patients select those indicators which they think are most valuable. And then we have the prompts data. Of course, we want to combine the costs and health outcomes with the patient-reported outcome measures. However, only 2 of those 10 software packages are currently extractable within our electronic healthcare record. So this is kind of the burden we have now, because we stimulated the use, but now we have to kind of evaluate how to extract the data and present it in dashboards. So that's kind of the problem we're stuck in now. But of course, we have to start looking at yourself. So what did we learn and how did we improve to get better? And the main aim of value-based healthcare or data-driven healthcare of dashboards is not to create a dashboard, but it's to access the data and to present the data in a way that patients or the physicians can improve their patient care. And actually we divided up in 3 goals. So we have 3 types of dashboards. The first tool is to support collaborative decision-making inside the consultation room. So that's actually the expectation of a patient, patient-reported outcome measures, how much pain do you have. They fill it in before the consultations, and then we can discuss it as a physician during the outpatient visit. The second is to provide insight in lead times to allow up and down scaling of capacity, so the process times. So it's a weekly type dashboard. And the third one is to provide insights in common case mix influences to go for the plan, do, check, act cycles to improve your patient care. And it actually looks a little bit like this. So if the patient dashboards in HICS, which are daily refreshed, which is mainly used in the consultation rooms, and we have the steering dashboards, which are updated weekly or also daily, but used weekly. And then we have the population dashboards, which is more like a planning and how do we improve our pathways. And that's done quarterly. And looking at the patient dashboard, we have the prompt tools as a source, and either we use an external dashboard application in a separate application, which is not preferable, or we extract the data into our data warehouse and we present it in a dashboard in HICS, which is the preferred option, but not possible for 8 out of the 10 apps we're currently using. Now, if the steering dashboard, this was launched 2 weeks ago, and it actually shows the process times between, for example, referral and the first outpatient visit, and also the percentage of patients which conforms to the norm we set. This is still some dummy data, as not all norms were set properly, especially in the right bottom. There had something going wrong. But this is like the most important data, and it wasn't still available for physicians or healthcare professionals, which is quite odd because this provides the most essential information about the process. And at last, we have the outcome dashboards, where, in my opinion, mostly conform with value-based healthcare, which actually combines all the data into large dashboards, which are quarterly assessed in a 2-hour session with all physicians to improve the pathways. For our technical friends, if you're a clinician, please do not pay attention to this slide. We have our electronic health record system. We make a copy of it inside the CTQ system. We export it in Excel and we visualize it. That's the main pipeline we use for the population dashboard, so for the third dashboard. But for the steering dashboard, you want a refreshment every day, so you have to do that automatically. And this is actually the pipeline we are currently using. So we have our data warehouse, we put it in SS Tabular. It's a Microsoft tool, and actually the visualizations are refreshed daily. So each day you have the new refreshments, which are based on the data in the electronic health record system. So it's like the perfect system, actually. For the time's sake, I'll skip this because it's really in line with the presentation of Heleen. So you identify the population, subgroups, collect and analyze the data, and discuss the outcomes and improve it. And of course, we monitor the interventions in the dashboard. 2 examples, what did it bring so far? We compared in the hip and knee trajectory, we compared it improve collaboration. And what we actually saw is that most of the centers did made 2 X-ray images. First, after referral from a physician, from the general practitioner, so the huisarts. And secondly, if the physician rated it as, oh, we have to replace the hip, we needed to remake the picture because you need a calibration or bullet, which is shown in the right bottom, to determine what the size of your implantation needs to be. And actually, we switched it. So if there's a referral from a general practitioner, which aims, or with the clinical question, should we replace this hip? So is there any damage already? We actually put in the calibration bullet in the first picture, so it saves us 50% of x-rays made in this population. The second example is a totally different population. It's in a pelvic surgery operation dashboard. And what I actually showed is that once you present the data, and this is example the complication data, which was not filled out regularly, only in 20% of the patients it was filled out like it's supposed to. However, once we put it into action and we refresh it each week, the registration increased to 80% in 3 weeks. So only giving it back the data they want to see will improve your registration automatically, actually. I think I'll need 3 more minutes because, of course, you have also to look at the future, what's coming up. And one of the things is process mining. Like I started off, we can map all the activities and you put them into order and you actually see the pathway a patient's supposed to walk through. That's shown on the left. So an outpatient visit, a telephone, a consult, an inpatient visit, the OR, the consult after the OR, and an outpatient visit again. But actually, when you look at the data, we put in 300 patients. The data is not organized in the way we put it up. So there are a lot of elephant tracks going on. This doesn't look too good. If you limit it to the 80% most common pathways, you actually see this type of graphs. And this is already used in the consultancy business really a lot, especially at hot floors, how the processes are working. And actually, we are starting to look at this right now in a hospital setting. And it actually shows the pathways which are currently taken and is kind of the starting point from which you can improve if you do not agree with these pathways. And you actually can put in all the data, so the waiting times, the maximum times, the number of patients, so you can make it as tough to read as you want to, but it will provide you real good insights. We're currently in a pilot process with 2 vendors to provide this software to everyone actually in the hospital, but this is kind of the main innovation we're working on right now. So what's the road up ahead? To get the Gartner cycle again, we're currently in the descriptive phase with our medical self-service dashboard. We're currently still making them for them, but in the end, the aim is that there's a data scientist at each department which can make them by themselves. The diagnostic tools, that's more or less the process mining, which we're currently working on, so we're not there yet, but we're getting there. The predictive phase, more or less the capacity management, so how many healthcare professionals do we need in the upcoming days? And the prescriptive phase, of course, the decision support, where a computer assesses the data and advises us on what to do. Regrettably, we are not there yet. So to take home, start small, act fast. We have a Dutch saying, the hand of a child is filled easily. So start with a small indicator set, presented in dashboards, updated weekly, and you will see a lot of progress already going on, because insights will lead to a change, whether it is in the registration or on patient outcomes, it will get you there. The third one, I didn't go into detail, but start where there is energy, start only trajectories where the physicians are real enthusiastic, because if there's no energy, it will want to fly, and if there's energy, it will fly immediately. And the fourth bullet point is actually never forget to look at patients' values. In the end, we do it for the patients, so never forget that. Thank you very much for your attention, and I'd like to see if there is any questions.
Yeah, thank you, Joris. Very nice presentation, very interesting to hear how you are progressing in this use of the data that's available. Are there any questions from the audience? I see that people are already mentioning that they have to leave for other sessions. You get a nice remark that there's a lot being done in Isala already. If there are no questions, then I think we should end this session. There is one question coming up that might be interesting to answer. Are there any plans to team up with Santeon?
Not yet, because we made the collaboration in Improve collaboration, and Santeon is currently not accepting other hospitals to enter their collaboration as well. So we don't have any plans, but I think this is kind of becoming a national-wide anthem. So hopefully we will have the benchmark thing in the future over all hospitals and not only participating hospitals in collaborations.
Okay, thank you. Okay, thank you all for being here. Thank you. Thank the speakers for their presentation. It was very, very interesting. Thank Linda for helping in the whole preparation and making sure the technical stuff was working. If you want to get in touch, you can contact the speakers of today through us if you want, or directly. You can access Dash by going to www.dash.umcg.nl or mail us at dash@umcg.nl. Check out our LinkedIn page, follow them to be in the loop for future events that we organize. So thanks again for being here and hope to see you all next time. Thank you very much.